There's a third one we haven't talked about, Abemaciclib. You know, do people have experience with Abemaciclib? Mark, you have experience?
We have a trial, but we haven't. You know, it doesn't seem again to be particularly different to us.
Aditya, what do you think?
Yeah, it's another CDK4/6 inhibitor by a different company. The only difference we've seen is the side effect profile is slightly different, which probably relates to the fact that it affects the CDK6 more than the CDK4. So diarrhea is the most common side effect that's seen with abemaciclib, and the incidence of neutropenia is less, which could be a good thing, but some have also questioned that is it really hitting the target hard, because neutropenia is an on-target effect of CDK4/6. So you should be seeing neutropenia if you are hitting CDK4/6. The other difference is that abemaciclib is given on a continuous basis, while palbociclib is given 3 week on, 1 week off. But whether that's important, whether that would result in a clinically meaningful benefit, we don't know at this time.
Yeah, Kim?
Yeah, so I walked away from San Antonio kind of more excited about this drug than I had been at ASCO.
Really?
So at ASCO, we had the single agent trial. So one differentiator of abemaciclib versus the 2 other CDK inhibitors is at least there's some described activity and phase 1/2 studies with it by itself, not layered on top of endocrine therapy. So that's kind of exciting when you see single agent activity that, at least to my knowledge, we really haven't seen with the other CDK inhibitors. But this trial was powered on an overall response rate. It was supposed to outperform single-agent capecitabine in a similar patient population. It wasn't a randomized study, and it didn't meet its primary endpoint, although there were some prolonged responders in the single-agent trial. But I got a renewed enthusiasm about the drug because Sarah Hurwitz presented NeoMonarch, which is a preoperative study, endocrine therapy, and I can't remember, I think it was for 2 weeks with a Ki-67 endpoint, abemaciclib alone, or the combination of the two. And abema by itself and abema plus endocrine therapy resulted in greater than 90% reduction in Ki-67. So to me, that actually was quite exciting in that we saw such a significant reduction in Ki-67 in the preoperative setting with single agent abema. I mean, it was actually as good as preoperative anti-estrogen therapy. So I've kind of gotten more of a renewed enthusiasm from the results of that preoperative NeoMonarch study for this drug.
Right, and we have 2 large trials, I guess, we're waiting to see the results. So very similar to Mona Lisa and to Paloma.
Yeah, but we all want that single agent drug. We hate putting the good news about advanced ER-positive breast cancer is we're seeing a lot of long responders. I mean, in my practice, you get a CDK inhibitor first line, you either get fulvestrant if you haven't had it, or you get everolimus. That's kind of, but you can eke people out for quite some time, and then that switch to chemo is pretty harsh for me as the doctor. And so yeah, I'm hoping that we do get this drug in that space as a single agent.
It's really nice because that's a